called Epilepsy 101, and it's about the VNS stimulator as well. Our mission is to improve the quality of life for people with epilepsy and help them overcome their challenges within the state of Wyoming. Our objectives are to educate people about epilepsy, work and collaborate with agencies, and promote public awareness for people to understand what epilepsy is and know that it's not misunderstood. Today's basic topic is Epilepsy 101 and the vagus nerve stimulator. Our presenter is Dr. David Wheeler, MD, PhD, with Wyoming Neurological Associates. He's the director of the Wyoming Epilepsy Center. I'm going to introduce Dr. Wheeler today.
So today's talk is going to be a general overview of epilepsy, and this is really geared towards individuals who are coping with epilepsy as well as those who care for them. So we have an introduction to epilepsy titled Managing Seizures. Epilepsy is one of the oldest known diseases affecting humankind. It was described by Hippocrates in 400 BC in his very important text on medicine, human medicine called On Sacred Disease. In the Christian era, in the book of Mark, Jesus Christ was thought to have cast the devil out from a young man who had epilepsy. So clearly this is a very important disease that was understood by many important people. In the Dark Ages, however, epilepsy became identified with witchcraft and other sources of evil, and more than 200,000 people were killed as a result of this misunderstanding of the disease. And it wasn't until the mid-1800s when John Hewlings Jackson, one of our pioneers of the field of neurology, was able to define a seizure as an occasional, an excessive, and a disorderly discharge of nerve tissue on muscles. So what is epilepsy? Well, it's also called a seizure disorder. And by definition, it means that a person may have more than one seizure that isn't caused by some acute medical condition. Therefore, it's not really a disease, but a symptom of many different problems that may happen in the brain. It's a very, very common problem affecting as many as 1 in 50 people, and almost 10% of all people will have at least one seizure during their lifetimes. This makes it one of the most common neurologic problems and one of the things we see most frequently in the neurology clinic. So what's a seizure? A seizure is caused by the sudden change in the electrical activity of a certain part of the brain or of the whole brain at once. This results in a change in how the person acts or how the person feels. The type of seizure that the person will have depends entirely on which part of the brain is affected and how much that electrical activity spreads around. It can range anywhere from being hardly noticeable to others to a completely disabling condition. Seizures may come with warning signs or may not cause a loss of consciousness, and we refer to these as simple partial seizures. Simple partial seizures, or auras, may take many different characteristics, again reflecting the abnormal brain activity in which part of the brain is affected. But we see many different types of changes in thought or thinking, such as the commonly experienced deja vu, where you have a strong feeling that something has happened to you before, or the opposite of that called jamais vu, where something that should be familiar to you seems utterly strange. People also sometimes experience strange smells, sounds when nothing is there, a weird taste in their mouth, changes in their vision, racing thoughts, a rising feeling in the stomach, a tingling feeling in the body somewhere. There are also emotional changes that can happen that are characterized by fear or panic, or sometimes even a very pleasant sensation. It can cause physical changes that include dizziness, headache, lightheadedness, nausea, numbness, or a seizure can occur with no warning at all. So as you can see, there's a wide variety of symptoms that a person can experience as part of a seizure, reflecting the incredible diversity of functions that the brain takes care of. The seizure itself can again result in a number of different problems. It often leads to a change in consciousness, confusion, loss of ability to hear, the strange smell that we've discussed, a spacing out, a feeling that you're outside of your own body, complete loss of vision or blurring of vision or seeing things that aren't there. The physical manifestations are very, very diverse and complex and can include simple things like repetitive chewing movements or fumbling at the clothing, fluttering eyelids. Can also result in dramatic stiffening of the body, generalized shaking, falling down. Again, pretty much anything that the body is capable of doing can occur during a seizure. After the seizure, people often experience what we refer to as the post-ictal or after-seizure state. During the post-ictal state, people often experience a number of what we refer to as negative neurologic symptoms. So loss of neurologic function resulting in loss of memory or amnesia, difficulty writing, confusion, severe sadness or fear or frustration or anger, embarrassment. There can also, of course, be physical effects such as bruising, inability to speak, inability to stay awake, severe exhaustion, headaches, sick to the stomach, etc. So again, the impact of the seizure on the body and the duration and severity of the post-ictal state can take many different forms. And the severity of it has a lot to do with how intense the seizure was, how much of the brain was affected, and how long that lasted. Seizures come in a lot of different flavors, and as a doctor taking care of people with seizures, it's very helpful to us to categorize them or divide them up into different categories, so that we can then talk to individuals using well-known and understood terms, so that we all understand what we mean when we talk about certain seizure types. And there are also certain medications that work better for some types of seizures than others. So one of the main way to categorize seizures is whether they occur everywhere in the brain at once or begin in a certain location. And that's the distinction between a primary seizure and a partial seizure. So there are many examples of primary generalized seizures, including the very commonly seen staring spells or absence seizures, myoclonic jerks, which occur especially during waking up in the morning and start in late childhood, are another common example of generalized seizures. Partial seizures take a lot of different flavors and can be further subcategorized into either simple partial seizures or complex partial seizures. In a simple partial seizure, by definition, there's no alteration of consciousness, whereas in a complex partial seizure, consciousness is usually lost or severely altered. Either a simple partial seizure or a complex partial seizure can then spread to involve the whole brain and lead to what's characterized as a secondarily generalized seizure. And finally, I want to mention seizures that are not caused by epileptic activity in the brain, which are generally referred to as non-epileptic seizures. And these can either be a conversion disorder, that is a psychogenic problem, or they can be the result of some other physiologic problem that kind of looks like a seizure but isn't, such as a fainting spell, a stroke, or a migraine that can cause movements in the body that are similar to seizures. When we talk about seizure types, that's one of the ways in which we can categorize different types of epilepsy, but there's a lot of other pieces of information that we can use as well. So we talk about type of seizures, but also the age at which the seizures begin, what we think may have caused the seizures, whether the seizures are genetic or not, which part of the brain is involved, whether there are certain stimuli or outside influences that can trigger the seizures, how severe they are, how frequently they occur, whether they occur in the daytime or the nighttime or both, what kinds of changes occur when we look at the electrical activity of the brain, other medical conditions that may go along with the seizure disorder, as well as whether or not the seizures tend to get better with time. All of these pieces of information are very helpful in defining what type of epilepsy the individual may have, and that helps us better understand how best to take care of that individual. The diagnosis of epilepsy is relatively straightforward most of the time, but there are many presentations of epilepsy that are unusual or not commonly seen by primary care doctors. So it's critical that everybody who's suspected of having a seizure disorder be evaluated by somebody with expertise in epilepsy, usually a neurologist or a subspecialist neurologist called an epileptologist. These individuals will, of course, obtain a thorough medical history and do a complete neurologic examination. We do a number of blood tests to look for certain diseases or acute illnesses that can cause seizures. We do a brainwave test or electroencephalogram, also called EEG, which is the most important tool that we have to diagnose epilepsy. And then we always take a picture of the brain using either an MRI or CT scanner to get a picture of the brain itself to see if there's something wrong with the way that it's put together that would be a cause for epilepsy. The treatment of epilepsy is complex. The first medications that were used for it were the barbiturates, such as phenobarbital or misaline, and these were used, documented uses as early as the early 19-teens. The next medication that was developed for treatment of epilepsy was phenytoin, also called Dilantin, followed by Tegretol, and then Depakote, and then later the benzodiazepines. And until the 1990s, these were all the medications that were available to treat epilepsy. These medications are effective at stopping seizures, but also prone to cause a lot of very serious side effects. They can harm the liver, the kidneys, the bone marrow, the brain, the central nervous system, the peripheral nervous system, and they have a lot of interactions with other drugs. And so while they're effective at stopping seizures, that comes at a significant cost. So it's very, very exciting, was very exciting for people taking care of epilepsy patients in the 1990s when we began to see a tremendous increase in the number of available treatments, starting with gabapentin and felbutol, which came out in the early 1990s. This was followed every year or two by a new medication all the way through 2011, when we just found out that the newest drug, ezogabine, has been approved by the FDA for treatment of partial seizures. So now we have available 14 or 15 very good medications that are good at stopping seizures, good at controlling epilepsy, and in general have much fewer side effects, fewer dangerous problems associated with them. And each of them have their own special properties that make them more or less useful for different types of epilepsy. So as a neurologist, we have available a wide variety of tools that are very effective at stopping seizures. And for most people, one of these medications is good enough to get things under control and meet our stated goal in the treatment of epilepsy, which is no seizures and no side effects. So how do we choose the medication? Well, most of the time it's straightforward. The type of seizure or what the epilepsy syndrome is pretty much dictates which of those medications is most likely to be helpful. In about 2/3 of the time, our first guess or our first choice works very, very well, and the seizures come under excellent control. We also sometimes have to take into account the other medications the patient may be on, what interactions it may have with those medications, whether the first medication we choose for them is likely to be efficacious or not, what kinds of side effects the patient may experience, and how much the medication may cost. So while there are a lot of new medications available, because it costs the pharmaceutical companies a lot of money to develop them, they charge a lot of money to the insurance companies and to the patients. So we have to sometimes take that into account. One of the most common questions I get asked is, once a person's been diagnosed with epilepsy, do they have to be on medication for the rest of their lives, or is there a chance that it can be stopped? Well, the answer depends on a lot of different issues, but one of the things that's generally true is that if you become seizure-free on a medication and stay seizure-free for at least 2 years, there's about a 60% chance that you can come off medication and not need it anymore. Now, there are a number of things that make that more or less likely. So some of the things that make it more likely are that your seizures went away after starting the first medication, and it did so at a relatively low dose. You've never tried to stop medications unsuccessfully in the past. Your neurologic examination and your EEG are normal, suggesting that your brain function is normal when seizures are not occurring. Sometimes patients who have certain epilepsy types, like juvenile myoclonic epilepsy or absence seizures, or one of the benign syndromes of childhood, those folks often outgrow their seizures and are able to stop their medications. So when examining a patient and trying to decide whether or not they need to continue their medications, these are most of the factors I have to look at. And on the flip side, there are obviously significant risks that a person would be taking by making the decision to stop taking medication. So if they've been successfully driving or holding a job or otherwise doing well on their medication, they might prefer not to expose themselves to the risk of coming off medicine, even if they've been seizure-free and have all those other favorable factors. On the flip side, if the medication has been expensive or causes side effects, or they just would rather not be on pills every day, then they might be more likely to choose to go ahead and try to come off the medication. So for us, this is a very interesting part of managing patients with epilepsy, and it comes up, for those 2/3 who are lucky enough to become seizure-free on their first medication. It's a question that we begin to ask about 2 years after the diagnosis is made. So I think it's really important to understand that there are other ways to manage epilepsy besides medications. Probably the most important thing are lifestyle modifications. And by this, I mean taking good care of your sleep habits, eating a balanced, healthy diet, getting regular exercise, staying physically active, avoiding stress, taking your medications as prescribed. There's probably other things that I'm not thinking of, but there are many things that individuals can do to help keep their seizure threshold as high as possible and give their medications the best chance of working. For younger patients who have very severe epilepsy not controlled with medications, some of them can be dramatically helped by being put on the ketogenic diet. The ketogenic diet is a very strict regimen with essentially no carbohydrates, a very high fat and moderate protein level that puts the body into a ketotic state. And that's important and has an impact on epilepsy because the brain only uses glucose for food unless there's no glucose around, in which case it uses ketone bodies. So if you take away all the glucose and make your body make a lot of ketone bodies, that will change what your brain is using for food, and that can have a dramatic impact on the brain's energy state and whether or not it can have seizures. So that seems to work really well for some people. The problem is it's kind of a gross diet, and most people who could get to a refrigerator wouldn't stick with it. So it really only works good for kids who have tube feeds or who you have total control over and can keep them from getting into the fridge. Epilepsy surgery can be a way to cure epilepsy in certain individuals. The important criteria are that you have to have epilepsy that can't be treated with medication. So in other words, it's refractory to medication treatment. And by that we mean you failed at least 2 medications, and usually more, and usually 2 medications together. You also have to have seizures that occur at a relative frequency that's considered disabling, and that can range anywhere from 1 a week to many a day. But somebody who only has seizures once or twice a year probably wouldn't choose to go through epilepsy surgery. And then the final and most important characteristic is that the seizures have to come known to be arising from a part of the brain which could be surgically removed without causing major neurologic deficits. So in other words, there are pieces of the brain that can be taken out and individuals will do fine. But if, for example, the seizures are coming from the part of the brain that, say, controls language or memory, it would not be desirable to take that out. So we have to use our best tools to figure out where the seizures are coming from before we consider recommending epilepsy surgery.